Hey guys, welcome back to Baker Health Talks. I'm your co-host Mo. Are you getting good sleep? In today's episode, we're going to be talking about literally what you spend 1/3 of your life doing, sleeping. In this episode, Dr. Alison Kole is going to be sharing some great tips and tricks for how you can improve your quality of sleep. Stay tuned.
We have a great guest today. This is a non-repeat topic. This is the first time.
We have a first new topic.
Yeah, so it's sleep and everything related to sleep. Most people, I think, don't know that if you're a doctor who specializes in sleep, it's usually a tributary off of pulmonology, typically. And so we can cover that area, but I think sleep is a topic that doing this as long as we've done this to not have covered it is pretty wild, right? Because we've covered a couple of things more than once, like cardiology and so on. So I think it's more than about time that we cover sleep. Spend 1/3 of your life doing it, affects the other 2/3 of your life. And it's very, very misunderstood by doctors and non-doctors alike, by the way. I hear doctors quoting different things about sleep that I know are wrong. And so I think it's a great topic, and we have a very esteemed guest. We were chatting for just a bit. She's got a really interesting course, and folks who listen and watch us know I'm equally fascinated by the personal journey of people who do cool, creative stuff as I am by the cool, creative stuff they do. And so, as always, I'd like to introduce the guest and then get her personal journey, and then we could get into the medical aspects of it. But Dr. Alison Kole, it's nice to have you here. We're just meeting for the first time today. If you don't mind, maybe just a little bit about your background and then your origin story and like how you got to where you got and what you're doing and how you're doing what you're doing. And then we could get into a bit of a Q&A.
Sure. Well, it's a pleasure to be here. I am a pulmonary critical care and sleep physician. So back in the day when I lived in Englewood, I worked at Englewood Medical Center, and I worked for a group there, and I did pulmonary and critical care, and that is just when around the time that I had finished sleep. But I had originally kind of planned a path that was just primarily pulmonary and critical care, and then my dad had some health issues, so came back to the Jersey area, did all my training out in Southern California, Cedars-Sinai and UCLA.
From Jersey?
I'm from Jersey. I'm a Jersey girl who somehow was allowed to escape and go get my training on the West Coast.
Wow, okay.
Which I think is really huge because the West Coast has been, in general, I think in medicine, very progressive in how they've approached things, just in terms of organizing large multi-specialty groups. That was sort of kind of a later thing to happen in Jersey. We were about a decade behind or so.
Yeah.
And I worked with somebody who was really into sleep. I had been offered a sleep fellowship position, and I had decided I just wanted to kind of be an attending. You know how like you kind of feel like, am I faking it or am I really an attending? You kind of have to sow those oats.
Yeah, 16 years later, I still ask myself.
I know. So I kind of felt like I had to put on my big bag of attending shoes, and my dad's health kind of stabilized. So I was able to then go back after kind of that exposure to somebody who was actually implementing sleep in the real world and go, oh, I want to do that. I want to get that education. So went back, did my year of sleep fellowship, got recruited over to a large multi-specialty organization in a different part of Jersey. And I really got a chance to build a sleep program from the ground up. They didn't have anything like that. And it was such a cool journey to be able to really affect change, because it really involves like a change in culture. Like you've got to get your CEO on board. You got to get the board of directors on board for what you could really do with sleep. And it became really successful. We ended up recruiting a bunch of people. If anything, we had a bottleneck because we had more patients than we had providers to see all these folks. And then this little thing, called the pandemic happened. I kind of routed all my energy toward critical care, which was asked of me. And then toward the end of that, I just decided, I'm like, how I would literally sit in the ICU in between patients, and all of a sudden this like obsession with doing something different, doing something on a greater scale, having a better impact with the remainder of my career became this like thing I could not overlook. I just was not happy doing patient after patient after patient. It's not that I don't love to see patients, but I just was like, I'm answering the same questions for them. I'm dealing with the same issues, but I'm not seeing them get healthier. I'm just seeing that I'm managing. And, there's nothing that teaches you more about why we need to take care of ourselves than basically a global pandemic where you're seeing the types of people who are getting really sick, right? And I'm seeing people who are unhealthy, who are obese. A lot of them, I am most definitely sure, had untreated sleep disordered breathing. It just wasn't talked
Sure.
about. It was just, it never came on their med list because they were never screened for it.
Right.
But you're seeing the same type of patient. They have hypertension, they have diabetes. You know, these are people that have, even the young people that we're seeing, they had something underlying it. They were obese. They had something. And I'm like, how do I affect change to try to change the, I have this sleep training, and I really started to see sleep as being so important as prevention, as really being necessary for health. And it's something, I don't know about you, but in my training, it was like a badge of honor that you didn't sleep. It was like, hey, I had this crazy call. Like I got like 2 hours of sleep, and you're like,
And there was
I
no
got
training
no
on
sleep.
it. Yeah.
Oh, and absolutely. It was just, we didn't talk about it, So even though people have been doing research in the 70s, it's not something I ever heard of in my training. So I just decided I needed to do something different, had an opportunity to jump over to continuing medical education. And I basically said, listen, I'll join you if I can really start to build sleep education. They were like, cool. And I was like, whoa, okay, awesome. And I had this, even before that, I was like, I need to do a podcast or something. I need to start to talk about topics in sleep that a lot of my patients are asking me about. And why not have it be this open book? They can just go and have a listen. And it's not just going to be me and my opinion. It's going to be me talking to other experts that may or may not be in the sleep field, and them sharing their views on things. And how do we bring this all kind of together? And so the Sleep is My Waking Passion podcast was born. And
That's cool name.
Yeah, it's really, really fun. So I've had a great time. It's probably my most favorite thing to do is to podcast and try to share some wisdom with the world.
That's
to
great.
try to make it a better place. Because in the end, we got one life. So what do we want out of it? And the side benefit is I get to spend a ton of time with my 7 and 9-year-old. And it's been such a blessing to hang out with them. So it's really,
And
it's
so
been a journey.
right now, Dr. Kole, you are doing the continuing medical education, and are you part of a sleep lab? Like, if patients do have sleep disorders or a primary care doctor wants to send you somebody, do you practice?
Yeah, so I still have very small out-of-network practice.
Okay.
I very deliberately didn't want to deal with insurance. Plus, quite frankly, if you're not in a large group these days, what kind of insurance negotiation power do you have? It wasn't a lot. So by networking, by having really strong relationships with people I trained with, was introduced to an organization in Laguna Hills called Oak Health Center. And they're really a mental health organization. And they found this incredible need for their patients to need to have their sleep addressed. And yet there's so much inertia because there's nervousness about discussing mental health issues and, just the inherent nature of maybe having depression or having really severe anxiety can sometimes even cripple you. But then if you're not sleeping well, it makes all of that worse. So being able to be a safe haven for them to come and really talk about their sleep. And we address sleep issues that otherwise they may have ignored because they didn't have the motivation to actually go to that appointment, book that appointment, go take time out of their day to go see them. So it's been really nice because I can spend as much time as I want with my patients. I really try to keep their health a priority. And then, we offer things like we started using Reimbursify so that if they, have out-of-network benefits, we can submit all of that for them. So it makes it, they get some reimbursement for that. So just trying to make it as seamless as possible for them to really enjoy talking to someone who just loves this subject matter. And they're really complicated sometimes because they've got really deep trouble with their sleep. Many of these people have felt like they almost have that as their identity. I don't sleep. And I myself, having been through a ton of insomnia during the COVID pandemic, doing shift work and everything,
Right.
I literally felt like I was going insane. I'm not even at their level. So I can only imagine what they're going through. So being able to sit there and say, okay, let's press pause and look at the patient and talk to them about sleep. But it's not just like, okay, this is my advice. Bye. Have a nice day. It's kind of putting into practice what I learned from Jen Martin over at UCLA about cognitive behavioral therapy. It's really about what is really going on here. How are you talking to yourself? How do you approach how do you identify with your sleep? Are you judging yourself because of it? So many common themes where people are like, I'm a bad sleeper. I just can't do that. There's all this like negative self-talk, and sometimes even addressing that's usually impactful because then they start to realize, no. you've got a lot more control over some of your difficulties with sleeping. And sometimes it's all about something as simple as talking to yourself in a really positive way. Like, I can overcome this. This is just, a barrier to me having optimal sleep, but it doesn't define me. And also not judging it if you have a bad night. So many of us tend to be like, well, I'm a horrible sleeper. I never get this. And then, they'll have like one good night out of a month, and it's kind of the self-fulfilling prophecy because they go to sleep, and then they worry about sleeping or trying to sleep. And then that act of actually trying to sleep makes it that much worse. So it's one of those things that's like a real Zen philosophy, if you will. You kind of have to let go and surrender to sleep. I think that's a great way to describe it. I read that in a book somewhere, and I was just like, that's it. You have to surrender to sleep. You've got to just allow it to happen. And if your mind's busy that day, have a plan in place to try to make that happen. And also don't judge it, because the more you judge it, the more your sleep is going to elude you.
That's incredible. I have a bunch of questions about what you just said. But before I get into some of the questions, it's interesting because probably the most interesting thing you said there was that comment about how like people self-manifest pathology. So maybe they're not the best sleeper, but they say I'm not a good sleeper, and they turn a 2 into a 10. And that like self-psyching yourself out about like some pathology you may have, and then how our perspective or our reflection on what may be something wrong with us or something we could improve on has as much an impact on it as any medical intervention. I see that a lot. So I have, as a pediatrician, I get patients, of course, who have ADD, who have, obesity, anything. And it's a tricky thing as a doctor, because I think, especially in the sensitive kind of environment we're in these days, where everybody's hyper aware and you have to choose your words carefully. And I'm from Jersey, so I just talk. And I think,
And we both.
I like to think like that. I like to think I'm sensitive to my patients. I really feel that way. But sometimes I think, communication to patients and patients to themselves, like picking on that theme, is a very underrated tool. And what I'll see an example of this 100 times, a day, where someone comes in and they're like, Dr. Baker, I think Jimmy, let's say Jimmy's 8 years old and he's in like third grade or whatever. I think Jimmy has ADD. I'm like, okay, tell me why. And then the dad or the mom will be like, well, he doesn't finish his homework. I'm like, okay, well, does he like finish basketball practice? Oh, he loves basketball practice. He could do it for 2 hours. Okay. And the teacher said, sometimes he talks when he's outside. I was, okay. If he's, playing a video game and he loves a video game, does he constantly get up and interrupt himself? No, he doesn't. So on and so forth. And then the dad's like, I'm like, okay, I get it. I'm hearing a lot of what it is to be an 8-year-old boy. And I have 2 sons myself. And then there'll be a comment, like almost because of my line of questioning, which is, I think, objective, right? I'm not passing judgment. The parent might weigh in and be like, no, but doc, I think I had ADD too. And there's like a projection that takes place now. And so that self-manifestation that you're talking about, imagine then like another leap of faith when it goes to the kids, right? As a pediatrician, you get a lot of parental projection or anxiety or whatever. And sure, the kid might have traits of it for sure. Or the kid might have traits, needs to work on his eating habits for sure. But like we get kids that come in now, not infrequently, like a 14-year-old kid where the mom's coming in out the gate. Hey, I lost 40 pounds and I always struggled with my weight. And the only thing that fixed me was Wegovy. So I want Samantha to get it. Right. Now, that might end up being the right thing, but like to just be like, let's skip because I went through this struggle and this was my journey and she's my daughter. And so it must be, and that you multiply that through any pathology. So as a pediatrician, you see that all the time. And then when my kids get older and they're closer to adulthood, like 17, 18, 19, I see what you're talking about, where people, they self-manifest a lot. Like if you, just what you said about sleep or, I'm depressed. Okay, tell me about your depression. Well, my boyfriend this or my husband that or whatever. Of course you're down. And there may be traits of depression, and many people are floridly depressed and need to be. But I think feeling depressed doesn't mean you're clinically depressed. Or having some eating issues doesn't mean you have an eating disorder. Or we pathologize things. We're quick to pathologize and quick to diagnose and self-diagnose. Like, it's not just doctors. Patients do it themselves and come to us ready. And they're like, hey, I'm a 10 out of 10 in this. Fix it. And then when you try to unwind it for their benefit, sometimes I think the communication part is tricky because we're trying to understand just where the line in the sand is, and that might determine intervention. And it's kind of a journey we have to take together. And so when I was listening to you talk about that self-manifestation, like, I'm a bad sleeper, right? And then like, I would have never thought in a conversation with a sleep specialist, I would hear cognitive behavioral therapy, right? That term being spoken in a conversation like this, but it's actually fundamental to a lot of these conversations. And I don't necessarily think of it that way, but now that I'm listening to you talk, that's kind of a journey you have to go on is, the patients, we only know what the patients tell us. And so what they tell us and how they tell us is not necessarily exactly what the story is. And so we have to be detectives too, right? And we have to say, well, when you say this, is it really this or is it more that?
And one of the fun things about having ventured now into creating a sleep telemedicine practice, yes, I love touching patients and seeing them in real life, but being able to kind of witness them in their own environment, you can learn so much just by your observation, especially in sleep when you think about it. Because maybe I'm having someone who's like, they're just lounging out on their bed. I'm like, how many hours a day do you spend in your bed? Okay, so we have an issue where we need to create some boundaries as to when you spend time in bed versus not. And, I've learned definitely for my younger patients, because they may be living at home, they may only have their personal space in their bedroom. How do you create a space to relax that you still have your own me time, but you're not spending it entirely in bed?
Oh, right.
And so it gets into a little bit of like, are there little ways to, it's how you look at yourself, but also, I think sleep hygiene in a way gets a bad rap because people are like, we can't fix your sleep just by dealing with sleep hygiene. I concur, but let's not ignore it either. Are there little tweaks that we don't even think about that we do that kind of disrupt our sleep? A classic is spending more time in bed than we should when we have trouble sleeping, right? We have trouble sleeping, so now we extend our bedtime hoping that our sleep is going to be better, and then it gets crappier and crappier and crappier, and then we've got to, upright the sinking ship.
Right.
Because now our insomnia is getting really out of control because now our brain is so confused with what the purpose of bed is.
So let me ask you some, I don't want to say rapid fire, but let me ask you some like poignant questions about
Sure.
like all over, just the stuff that I see as a primary guy, like across the board from the kids and from their parents all the time. So sleep hygiene, you mentioned it. Define it, please. Is it customizable? Are there some common denominator aspects, common myths, definitely should do and definitely shouldn't do?
So sleep hygiene is sort of like what your behaviors are around bedtime. So there are I think, I'm not going to say they're common myths, but maybe they are fairly common. I think the one I did touch on is just deciding that you need more sleep, so you're just going to spend it all in bed, even if you're not tired. The second thing, I don't know if this would fit more into sleep hygiene or just a general approach to sleep that I have. I don't really define all of these separately, though. It would be focus on your wake up time. Make that the most consistent thing that you do. A lot of people are very focused on, well, I need to go to bed at this time. But then getting into a bit more of how we approach sleep, you can't just go from, hey, I'm on the computer, I'm working on a spreadsheet, I got a deadline for work, I'm going to do everything. Okay, now my work is finally done. Okay, it's time for bed. You can't just switch off like that. We're human. We need some downtime. So building that in, I would call that good sleep hygiene. You're just building in a routine that makes sense so that you could actually engage with sleep. Don't drink a ton of alcohol right before bed unless you anticipate a crappy night of sleep, because you're going to have a crappy night of sleep. You may fall asleep initially quickly, and then as you metabolize the alcohol during the evening, you're going to have a lot of sleep fragmentation. You kind of pass out, go into this deep sleep, and then you have this like REM rebound. And so you're constantly kind of waking up and having very fragmented sleep toward the end of the evening. I do think caffeine is a mixed bag. A lot of people feel like, oh, caffeine doesn't do anything for me. Ultimately, you're sort of, what you're doing basically is you're decreasing the desire to actually go to sleep. So even if you can fall asleep, I don't think it's going to be the same quality. I've heard people argue with me, nah, it's not the case, I'm just fine. And I do think people are different responders to caffeine, but just common sense things. If you're having difficulty, don't have an espresso at 10 p.m. and then expect to go to sleep right away. Exercising right before bed. I used to tell people all the time, oh, you need to wait 3 hours. There was actually some more recent literature that I read that said maybe it's okay for up to about an hour and a half before bed. I think you see how you respond to that. Just be like, you don't have to go with what a study says. How do you feel? I mean, if you can really feel like I got my workout in, I feel tired, got my hot shower, core body temperature is able to cool down, I can go to sleep, great, then do that. But for someone like me, I can tell you if I exercise in the evening, that definitely sort of amplifies things and revs me up. So I avoid doing that. So part of it is finding a routine and behaviors that really work for you personally. And that's the cool thing about sleep is that we can have these broad strokes of what we tell people. But in the end, it's sort of like part of what I have found is one of the best ways to sleep is start to get in touch with what really jives with you. And that may even be your circadian health, meaning if your routine is, I'm a night owl, but I got to go to my 9 o'clock job and I got to be up at 7 o'clock in the morning. So I do all of that during the week and I really skimp on sleep. And then I'm throwing my sleep schedule off on the weekend because I can do whatever I want. But then I don't really feel great because I haven't really been doing the right thing. And then I go back to this wonky schedule. How do you fix that? Can you align your, circadian rhythm better to what you need to do, what your priorities are, be it your job or activities or what have you?
That's helpful.
Yeah.
So it's not one there. So sleep hygiene is important, but there isn't one form of sleep hygiene. You have to get to know yourself. And there's some common sense measures that are fair generalizations, not ubiquitous.
Keep your bed, keep your comfort. They say is the room temperature correct? Keep it cool. Cool actually tends to be better. There's actual data that supports things for cool bed sheets and things of that nature.
So 70, 68, what are we talking?
I have read 68 degrees. Yeah. That may need to be cooler for some people. And then you get into a whole bag of worms with people who are in the perimenopausal stages and they may have hot flashes. And so something that keeps them even cooler might be right for them. I personally, honestly, sleep best at around 71. My husband would rather it be 65. Mm-hmm. So we sort of compromise at my temperature because I'm the one who has trouble sleeping. But he sleeps fine, so it's okay. But, they say keep it dark. I'm a big fan of that in terms of basic. I know a lot of people sometimes want to keep something light on. Ultimately, I think it's better if it's more like a cave environment and dark. But if it's really something that's going to bother you, is there some compromise? Like if you need the TV on to fall asleep, set a timer so it's not changing shows and then waking you up. And some of these rules are just rules that I've come up with over the years to individualize a plan for a specific patient. I'm giving you broad strokes of what's generally recommended, but it may not be the right thing, like I said, for a particular patient. So you kind of, sometimes when I sleep restrict sometimes, some of the cognitive behavioral therapists will be really strict, like you got to no more than 6 hours, et cetera. I'm like, that might not be something a patient's willing to be adherent to. So do I need to flex on that a little bit? Or do I need to work on one part of it first? They get comfortable with the plan, know that I'm really working with them, and then I do some of the heavy lifting later on in in another visit and really get them more optimized. So sometimes even if it takes a little bit theoretically longer for them to get there, if I have their buy-in and they really trust the process, that's in my mind, 90% of the battle.
And speaking of specifics, I didn't want to lead off with this, but many people come in and they will, again, in my world, it's them asking about their teenager every parent thinks their teenager's sleep is screwed up. But even for themselves, what's the optimal amount of sleep? Because you'll hear 8 hours, 9 hours, 7 hours, and even varies by age. Now, there is for sure in the neonatal, in my infants and toddlers, there's a huge skew in terms of hours. But talk about just let's start with adults. Is it true that there's a rather narrow amount of sleep that far below or far above that doesn't make sense? Or is it a lot more fungible than what we hear?
So the general recommendation for the National Sleep Foundation is roughly 7 to 9 hours of sleep. And where does that come from? Well, it's sort of like when you think about school, right? Where most people kind of fall. The window is the bell-shaped curve is the most people kind of feel okay between 7 and 9 hours of sleep. Are there people who tend to be shorter sleepers? Yeah, there's actually there's now looking at, sort of a genetic predisposition. Some people naturally are going to be shorter sleepers. That does not mean that you're a rock star because you sleep 4 or 5 hours. That's too little sleep, even for the shorter sleepers. But they may kind of be optimal at around 6 hours, between 6 and 7. There are some people who need a longer amount of sleep. And what's very interesting is when I've talked to Sherry Ma on my podcast, she's done a lot of research with sleep extension, particularly in the athlete population, primarily because they're kind of easier to measure because they have very finite sort of goals. Like they want to get better at whatever sport they're doing. And what she's come to find is you can actually extend sleep in somebody who, especially if they're sort of physically very fit, their bodies may need more sleep than anticipated because they need that time for recovery, and slowly, incrementally increasing their sleep to kind of maximize it to the point where maybe they need 8.5 or 9 or 9.5 hours. You'll hear about these Olympic athletes that really do prioritize their sleep. For the most people, it's roughly 7 to 9. Ideally, how I look at it is, do you feel refreshed? Do you feel like your sleep quality was good? Nobody's telling you that you're doing anything weird or funky or your legs are not kicking. Nobody's telling you that you're not breathing right. There's no signs that there's an underlying sleep disorder, and you consistently feel really good and have good energy and you're sleeping 7 hours. That's probably all you need. I will tell you personally, what I have found on my journey to get better sleep is regularity. We're getting some new data about the importance of having a very regular routine sleep schedule. That has been hugely helpful to me. And if I get 8.5 on one day because I'm extra tired, dollars to do, I'm skimping on another time. I'm about a 7.5 girl. That's optimal for me. I can't get 8 hours consistently. It's just not how my brain operates. It'll skimp somewhere. I will, I will ultimately end up getting 7 hours somewhere else or 6 hours somewhere else. And in the end, you average it all out at the end of the week and boom, I'm at 7.5. So that seems to be my particular sweet spot. You might need more, maybe 9 hours. If you're really finding you're like, listen, I'm like 10 hours and you're not feeling good, that's a different beast. Because then it's like, oh, and this is very important, especially for pediatric patients, because this is how they present. There's just more and more sleep, and they're not feeling refreshed, and they're having a hard time getting up, and they truly are sleeping that long. Maybe they have something else. Maybe there's narcolepsy, or idiopathic hypersomnia, or some other rarer sleep disorder that people may not recognize right away as being problematic. So it sort of depends, but yes, in essence, there's no one size fits all for that. I just spoke with someone just recently and they get 6 hours and that seems to be sufficient for them. I'm like, prioritize that, then maybe try to extend it a little bit, see if you feel that much better. Part of it's how you feel, and that is very subjective.
That's helpful. And then is it ever normal or is it always abnormal if an otherwise healthy 30, 40, 50-year-old with no known underlying medical condition takes naps regularly?
Some people really do benefit from naps. It's, I think what's important is, how are you truncating your sleep? Some people may feel like, okay, well, I am someone who really can't sleep for longer than 4 hours at a clip. And then they may have sort of a biphasic sleep pattern where they'll sleep for 4 hours here, sleep for 4 hours there. While it's theoretically not considered to be ideal, the reality is that if you look at history, back in the day before we had electricity, people did kind of sleep in clumps. So people often didn't get a solid 8 hours. That actually wasn't even normal or usual. And my husband's a classic example. If given the opportunity, he really benefits from a 20-minute power nap. He's like a different person. It does not interfere with his ability to go to sleep at night. And having slept next to him, I'm not hearing any signs of sleep disordered breathing or anything else that's really of concern to me. So he just is somebody who likes to nap. If you ask me to nap, I'm like, are you asking to destroy my sleep this evening? I'm not a good napper at all. And duration, matters. If someone's struggling with their sleep, they're having difficulty sleeping at night, taking a nap for 2 hours in the middle of the day is not a good plan for you if that's deliberately impeding your ability to sleep at night. So again, I'm not going to say it's absolutely abnormal. What I would say is you want to think about, if you never really needed to nap and suddenly now you do, is there something else that's going on beyond just the stress or busy work week? is there something that's impeding the quality of your sleep, something that's happened that you need to explore a little bit further? Classic would be, obstructive sleep apnea,
So that's
unfortunately.
my next question. So I think up to this point in the conversation, like understanding, basically, I think of what we discussed up till now is loose boundaries on normative sleep, sleep hygiene, what are the right hours, so on and so forth. Now I'd like to segue into pathology. So I think what I've heard from you is, look, sleep is important, but it's different for everybody, and you need to know what's right for you. And there's some loose boundaries, but you know better than somebody else, but you need to know. That's what I've heard so far. Segueing into pathology, because there's real pathology out there. The meat and potatoes of it is obstructive sleep apnea. Now, you've mentioned like hypersomnia, narcolepsy. There's a lot of those 1-2% things, but the bulk of the pathology we see is under this very catch-all obstructive sleep apnea. I know it's subsegmented and so on, and I'll leave that to you to describe. But let's just walk through this, because sleep disorders, obstructive sleep apnea, are grossly underdiagnosed. Most people who have sleep issues don't know they have sleep issues, right? As opposed to most people who suffer from headaches, debilitating headaches that affect their life, come to the doctor saying, I have migraines or I have headaches. Most people who have asthma and difficulty breathing aren't underdiagnosed because they're having difficulty breathing. But sleep is a funny thing, because most sleep issues you're not aware of because they don't manifest in a way that's, at the tip of your fingers. And so, you all these public health studies and all, I mean, you've read enough studies. We've been a part of a million studies where we know we take them with a grain of salt. The ones that I have no problem believing is that say most people who have sleep issues don't know they have sleep issues. It makes all the sense in the world to me for those reasons. Let's just walk through this, because I think, the statistics are anywhere from 20 to 50% of people have some sleep issue, and more than 50% of people with a sleep issue don't know they have a sleep issue. And so in primary care, we do stuff like universal surveys, to like screenings and stuff, to see and ask questions. Can you talk a little bit about what are the signs for someone that they should contemplate? Like, what is it that's happening to them? Like extreme somnolence or irritability or depression or gaining weight, whatever, that should prompt them to say, wait, I think there might be a sleep issue. And then we could get into partners, because a lot of times it's the partner bringing it up. Like I have to, you ask the guy, he's like, I sleep fine. And the wife looks at you and she's like, I have to like literally like shove you 30 times because you stop breathing, and you're sitting there as the doctor and he's shocked to hear it, and they've been married for 20 years. So we could get to that in a minute, but just the average person listening to this, what are some red flags?
So red flags are, I love that you brought up the partner, because I think for me, you're absolutely right. You're essentially unconscious when you're sleeping. And, obstructive sleep apnea can manifest in many ways. Often the partner is so key to bringing some of the more common symptoms. I really think you're not breathing properly. Your breathing just sounds weird. It sounds whatever, like a freight train when you snore. Different symptoms, how they describe it, or like, you're snorting yourself and you don't even know. So a lot of times it's like the loudness, there's some concern about their health. They may actually tell you things about position that are helpful, like they're much better when they're on their side, worse on their back. That may potentially have some implications in terms of what you might consider for treatment or what you want to look for on a sleep test.
They stop breathing. They'll tell you they stop breathing sometimes.
Yeah, and
I have to
witnessed apneas is what we call it in medical parlance, but they stop breathing. One of the things that actually is quite fascinating is I can't maintain sleep. So there are people who will say, I keep waking up and I fall back asleep, but I just keep waking up and I haven't figured out why that is. That could be a manifestation of obstructive sleep apnea as well. Other common things would be your level of fatigue. So do you feel super tired, like you can barely keep your eyes open, right? Those people exist. So that's really kind of more obvious, because even they're impacted. They're like, oh my God, like I'm just dragging the rest of the day. But it might be very subtle, like, I don't know. I just feel fatigued.
Right.
I have a hard time concentrating when I'm at work. It may be, that they're sort of like starting to gain weight, as you mentioned, and they can't really explain why it is that they're gaining weight. And then you have things that are occurring, like comorbidities that start to arise. And it would be nice if we could identify these patients even earlier. But comorbidities like, hey, My blood pressure has been high. I don't have hypertension. I get that a lot. I don't have hypertension. It's just that on several occasions they've monitored my blood pressure. But it's just because I have white coat syndrome or what have you. And you're like, maybe there's something else going on here. So they may notice something just seems off with their sleep quality. Just that it just doesn't seem to be restorative when they wake. They don't have that same get up and go. They don't have that same laser focus they once did. So it can be very obvious, and you pointed out a lot of the obvious symptoms, or it might be just a little bit more subtle. And for women, it can be even more subtle than in some men because they may not feel tired. Again, insomnia, difficulty sleeping seems to be a real big complaint of many women. And then they may actually not be really easily detectable on a standard home sleep apnea test. So we do a lot of home sleep testing these days, and you may miss them because they might have more subtle upper airway resistance where their snoring is actually waking them up quite a bit. And there's a slight narrowing of the upper airway, but it doesn't meet that 3% drop in your oxygen saturation criteria. So they kind of fall, you're like, oh, the home sleep test, whatever, it's fine. And in those people, you really want to push for more in-depth testing. So kind of depends on your patient population. And, there can be I'm trying to think of some more unusual symptoms that I've heard. Nocturia, so people having to get up and pee a lot at night. That's another tip off. Sometimes people will just describe having odd dreams, and it might just be around the time when you might anticipate a REM rapid eye movement period. So it might be later on in the evening, and they go, I wake up and I have these dreams of drowning. Sometimes they're kind of scary dreams. That's almost like their body saying, wake up, you're not breathing properly, so I'm going to give you this really messed up dream that's going to get you to consciousness to wake up.
That's interesting. I never knew that the type of dream you have can tie to a clinical kind of particularity.
I've definitely had folks where and they can recall the dream. They really
Okay.
feel like they're almost like they're drowning. It's usually something surrounding feeling like there's a pillow over their head or some symptom of drowning basically. And then they wake up and they're like, oh, okay.
Right. It's compromising their breathing. So
yeah. And so they
okay.
wake up from that reason and just
That's
happen to
interesting.
recall that memory.
Okay.
Some people actually act out their dreams. And so which is a phenomenon if it happens in rapid eye movement sleep that we call REM behavior disorder. That's a little bit more unusual, but sometimes we do see that and really treating the sleep apnea. It's almost like pseudo REM behavior disorder, like treating the sleep apnea calms those behaviors down because they're not getting activated in REM sleep abnormally because their breathing has been restored.
So let's say someone's listening to this or they have like a good PCP and it's on the table. The conversation, there's something there that they're discussing it and they're wondering like things are not perfect, right? They are a little more tired than they think they should be, or their partner has mentioned that or they could hear them down the hall. There's something there. And now they want to take the next step and evaluate it. There's enough there that it should be evaluated. Sleep study. So someone comes into your ears perk up. They're engaged. Everybody feels there's enough to do. What can you go through the sequence of diagnostic evaluation?
Sure. So if I'm concerned about, particularly, I often screen people for sleep disorder breathing because it's very simple to do, and especially for my insomnia patients. Just by way of people knowing there's some new technology out there. No CPT code attached to it, so we're not covering it by insurance, but they even have sort of a home polysomnogram. So there's a couple companies that are out there that are doing that sort of work. I find it fascinating because I think it would be really cool to be able to bring a polysomnogram home and be able to get some of that more detailed information, particularly in the patient where they're not the highest probability, but you can't quite feel comfortable that they're negative. And a home sleep test in a high pretest probability patient, what is the likelihood they have it? You're probably going to get your answer 90% of the time. But as your probability or your suspicion goes down, that home sleep test actually tends to become more inaccurate, and you may be missing more people that may have more mild disease, for example. So in general, what I do is I sit there and I go, okay, first of all, if you're using insurance, quite frankly, it's whatever insurance is going to cover, right?
Sure.
The gold standard is to come in, they hook you up with a bunch of electrodes, they watch you overnight. That's what we call a polysomnogram. That is not something that we do often in most patients. Most of the time they're getting what we call a type 3 home sleep apnea test. And it's just called that because of the certain things that we're measuring. They're able to often may or may not measure position, definitely measuring what's going on with your oxygen levels. You may be measuring what's going on with your heart rate. And then depending on the device, depending on what algorithm they use, sometimes it's changes in arterial tone. That's a specific type of algorithm that they're using. Or maybe it's more classic and you're actually looking, are they breathing while, they're trying to breathe? Are they actually moving their chest wall, for example? So those are some of the parameters that we look for. And that, again, is done in the comfort of your own home. There's even some suggestion that multi-night testing may be better than just one night of testing, but still one night of testing seems to be the mainstream. And again, I hate to bring up dollars and cents, but at the end of the day, it's all about what you can get reimbursed, compared to what technology is available, what that technology costs you as an organization to use. But in general, that's one way that we screen. If that were to be negative, do you pass go? And in the ideal world, the answer is no. You really want to confirm that a type 3 test is indeed accurate. And that's where I might push to have someone come to the sleep lab if they're willing to go and sleep overnight. Or now, if people are willing to pay out of pocket, it's considerably cheaper than coming for an in-lab sleep study, but you can actually do a type 2 type of home sleep apnea test or even a home polysomnogram. And you should be able to more definitively exclude any sleep disordered breathing.
So just so it's clear, so we have, as the doctor, you and the patient agrees, there's some suspicion. Step one, the at-home sleep study.
Yes, and sometimes how you define it or what defines a high pretest probability patient. Well, the easiest thing is, okay, do they have any of these typical comorbidities? Do they have a big neck? Do they have a tight airway when you look at it? Are they overweight? Are they male? Male gender predisposes you to all of that. If they check off all these boxes, you can even use screening questionnaires that we use for pre-surgical patients, like the Stop Bang questionnaire. You could say, oh, okay, this person's high probability, great. Sometimes it's more subtle, like they just are not sleeping well. They do have the snoring, so they have some of those symptoms. They may not look like your typical patient. I'm going to be seeing someone this week, thin, Asian, male, definitely has sleep apnea, doesn't, what nationality are they? So, meaning what's their ethnicity? Because if you're Asian, the Stop Bang may not be so good for you in being able to determine what your actual risk is. So the tools that we use and which population they're good for make a difference. Do you have a family history? I'm very excited by family history because we tend to look like people we're related to. So often our airways are going to have the same issue. So if you've got a long-standing family history of people having something funky going on with their breathing at night, that would raise my, pre-test clinical suspicion. So I try to give them my patients a sense of where I think they fit in the probability scale, and then we do their testing. Now, there's times when someone I really don't think has sleep apnea, I just want to make sure I'm not missing anything, and I may screen them very quickly with the home sleep apnea test, and they may be struggling with their sleep. They may have insomnia. I don't push right out the gate for them to go for a polysomnogram because I think the risk is probably pretty low. I just wanted to take that low-hanging fruit off the table so I could focus on what we're going to do for their actual sleep quality. So it kind of depends on the patient, but generally speaking, those are the steps. Yeah.
If you go down that path and now you have somebody in your post, at home or in lab studies, and you're like, okay, this 44-year-old male or female has legitimate obstructive sleep apnea and sleep issues. What now? So therapeutically, it's obviously specific to what the issue is, but a lot of people, I'd say half the folks I know, I'm not even talking about patients, I'm talking about people I know personally that are told to get a CPAP machine, at least half, probably more, never use it. And so they're told to use it and they just don't want to use it. And then, of course, there's other things, whether it's obesity or whatever. Can you go down, okay, if you do have diagnosed obstructive sleep apnea, here's the potential therapeutics, and then talk about some practical ways around it, because almost the whole list of them are not easy to engage in, whether it's lifestyle changes or this contraption that's on your face. And sometimes you go down, in my population, it's much more ENT driven.
Mm-hmm. Yeah. So just in terms of treatment options, I do categorize it in terms of severity. I think that's important. So if someone really, and and how we define severity may change in the future depending on, newer information. But generally speaking, it means that you've basically are not breathing properly. Your apnea-hypopnea index, how many times you either completely or near completely stop breathing per hours, 30 events or more. That's severe. For those people, I really strongly encourage a trial of PAP therapy. I want their airway to be open, and I really want to see if that improves their quality of sleep, how they're doing. It's correct that it's not universal for everyone, but the bottom line is that that's really gold standard for severe sleep apnea, at least in 2024. And I'm going to talk about more, mechanical means by which we manage sleep apnea. It's a whole other, it's going to be a new future, I think, with these medications as we find out more about obesity and OSA. It won't be a panacea because, let's face it, only 40% of people who are obese, like 40% of people with OSA are obese. So at the end of the day, it's not going to be appropriate to give people weight loss medications, for example, everyone. But we're not there yet. It's something that is new and exciting, especially with the new trial data that came out. But so CPAP really is the mainstay. But what else can you do? And, for more mild or moderate and non-compliant severe, and I always say, you got to prove to me you can't use CPAP, and then we can talk about other stuff just because, guess what? Insurance plans need to also agree with Dr. Kole's plan. I can't just do whatever Dr. Kole feels like. That's not how it works, right? So I still, even as an out-of-network practitioner, I'm taking a little sideways bend here, but, the bottom line is that I try to use insurance when I can, and certainly for CPAP and other things that cost a lot of money, you want to be able to use their insurance plan. So my visits might be out of network, but I certainly got to play in the sandbox with insurance when it comes to how I actually manage a patient. I actually really strongly like to consider, unless I think that they've got a huge neck, they're really, really morbidly obese, and I just think moving their tissue out of the way a little bit's not going to do diddly for them. You can actually entertain things like an oral appliance that's made by a dentist. There are a lot of caveats with doing that. You want to go to somebody who really knows what they're doing, has a lot of experience. And there are people who take sleep apnea courses. There are some people who actually become diplomats in the American Academy of Dental Sleep Medicine. So there's certain criteria that you could look for, that they have that extra education, that they're really dedicated. How many patients do they see in their practice? So, they really have a really good sleep dentist has a whole treatment plan in place. Multiple visits, adjustments are incremental. There's ways to kind of push the jaw back in the morning after they've been sleeping. Typically, we say about 50% reduction in AHI, but there's been some dental sleep literature that's actually suggesting that for some people, they may actually get near complete resolution, even if they're severe. Again, the problem is we have no crystal ball to really be able to predict who's going to be a great responder. Sometimes people who tend to be lateral sleepers, there's some data suggest that maybe they might be a better responder for an oral appliance compared to others, but there's a lot of factors that go into that. All you're really doing is mechanically kind of jutting the bottom jaw forward, so you're moving tissue out of the way. So again, if you've got a massive neck, I don't know how much that's going to do for you in reality. Then you have, for people who tend to be more on the moderate to severe side, even if they are technically obese, meaning their body mass index is basically 40 or below, there's Inspire therapy. So Inspire therapy is an implantable device. It's really hypoglossal nerve stimulation. I'm using the term Inspire because that's the name of the one product on the market currently that's approved, but there's others that are in testing. But really what you're doing is you're doing a surgical procedure to stimulate the tongue muscle to move out of the way in synchrony with your breathing. It's like a pacemaker for your tongue muscle, very simplistically. That can be very helpful for the right patient, and they do really try to take a look at the airway and what that looks like to determine that. And then you get to the pediatric population who often do benefit from, their tonsils and adenoids being taken out. And for people that really some of that stuff isn't working, sometimes it's really positional. I don't love doing this, but I've had people where if the only thing that works for them is a belt, then we strap a belt on them and keep them on their side. Right. Philips actually had a device that would sort of kind of vibrate to keep you off of your back. I don't know if they're still manufacturing that or not, but so there's been some neat sort of techie stuff that's been out there to kind of nudge you to stay on your side, if you will. Just we're creatures that move in our sleep often. I don't know about you, but I don't stay in the same position all night long.
Yeah, I mean, I will not share my sleep patterns. Nobody will ever come see me.
You'll get diagnosed with sleep apnea in a
Yeah,
second.
at a minimum. So that's very helpful. I have a couple of like edge case kind of questions, because I think like you did an amazing job of covering like the bullseye. Like, here's sleep, here's things that most people who have sleep issues deal with, and here's whom the solutions for most of those people. But I want to just kind of dance around some of that.
Sure.
This will be more rapid fire. Wearables.
Wearables. There is one wearable, I think. I forget which company it is that actually I think it was FDA approved or something to actually be able to, was it Samsung? Maybe it was, that may actually be approved for really being able to be a true tip off that there's some sleep disorder breathing. Is it going to replace going to see the doctor and really discussing what's going on with your breathing? I don't think so. But are these tools wonderful tools, especially if they can kind of screen things like sleep disorder breathing? Let's talk about the flip side of wearables, right? Are there some inherent dangers? Well, if you're obsessed with your Apple Watch and what it's telling you about your quality of sleep, or what your Oura Ring tells you, I think those are curious, but you really kind of have to marry it with how do you feel? Because if you feel like you're sleeping great and you wore some random ring and it's telling you that you're not sleeping great, if you start getting really obsessed about your sleep and now you're really not sleeping great, then you have orthosomnia. So you literally can make yourself nuts by becoming obsessed with what a commercial product is telling you. And that's the key. These are like commercial products. They're really marketed as almost like entertainment, if you will. So yeah, it's a fine gray line. I know the American Academy of Sleep Medicine has really worked hard to try to address the ever-changing technologies, and there's wearables, and now there's nearables, so you could put something next to your bed and be able to figure out what's, that's listening to you for snoring and other things like that, and tries to detect things without you wearing anything. So yeah, technology I think can be wonderful, but I also think there are some quote unquote dangers that you just need to be aware of.
One question I have is pharmacotherapy.
Sure.
As a sleep expert, are you ever like, yeah, here's an Ambien script? Is there ever a place for that?
I do believe that there is a place for prescriptions. It's been, now that I've transitioned out of a regular routine, day-to-day clinical practice, I don't actually write for any of those scripts, but I've also not had the volume of patients where I really felt it was necessary. Where I think if you look at even going back to the data, these were never meant to be permanent, every day you take something kind of medications, right? But if you're traveling short term, or you're having a particular event that you need to feel really on top of, and you want to use something one-off, and you're going to be having kind of that anxious, spicy brain that's not going to settle down. I myself have a prescription for Lunesta that I use on very rare occasions. Typically, I reserve it for when I'm traveling, because that just ensures I'll get some quality sleep as I'm adjusting to wherever I'm going. But short term, I've had folks that really have had an acute event that's tipped them over. They've lost a loved one, some, serious catastrophic stress in their life, and they just need something to kind of get them through so this doesn't escalate into something bigger. Sure, I may use something temporarily for them, but ultimately my goal is pretty much to get everyone off of medications. And sometimes I'll use things that may have a fairly decent safety profile, but let me sort of like off-label use, like trazodone, for example. That can be very helpful, but it's not universal, and some people feel like crap on it. So it's one of those things that's sort of like hit or miss, but I think it's pretty safe. You do need to wean off of it. A lot of the sedative hypnotics out there, do have potential for there to be what we call parasomnias. Like, they start doing funky stuff in their sleep. They may eat at night. They may try to do stuff and activities at night and be completely unaware of it. So there is somewhat of a safety issue. Yeah. So, and sometimes I just have patients that are used to being on those medications. And in order for us to think about getting them off, I first need to kind of really work with them on what is it that I think is really kind of broken with their sleep. And then can we start to back off on their frequency of usage? So part of one of the things I did in my old practice is really work with people to taper them off in a way where, and it was pretty amazing. Sometimes they were on 3 things. If I got them down to 1, I was like, I'm a rock star. Like, I may not get perfection here. So it's not going to work for everyone, but if we can, certainly getting them off of those heavy duty sedative hypnotics, I think would be recommended.
And so my other question was, like, you partially answered it already, which is, I was going to say on the modest end of the spectrum is like jet lag. So people like so I have cops that like 2 days a week, they're like overnight, and the rest of the week they're not. Bunch of nurses, they do like 2 nights a week or 3 nights a week overnight in the ICU, and the rest they're like mom for 3 kids during the daytime in soccer games. It's very screwy, like truck drivers. And then we even have had more than a few athletes, like professional athletes, who travel. They're like, it's
And
like,
even what's flight attendants?
yeah, like it's like seasonal. So they'll be like, listen, for a third of the year, I'm like, for a third of the year, half the nights I'm traveling to the West Coast for a game or something. And then I got like, it's complete dysregulation, right? Let's start with I don't want to say it's easier. Let's start with like, I'm a nurse and in the ICU or labor and delivery or whatever. And 2 to 3 nights of the week, I do 8 p.m. to 8 a.m. And the rest of the time I have 2 kids and whatever. What's the best way to manage that?
Oh, you were asking a really challenging question. I mean, sometimes for those patients, it's appropriate to consider some pharmacotherapy just to help them get regulated with their schedule. Are there, theoretically, what you try to do is you try to align their circadian rhythm. You try to keep them in the same rhythm if they could, ideally. That's really big ask for someone who's like, listen, I'm doing night shifts and then I've got all these daytime responsibilities. It's kind of not realistic for them. So this is where you might deploy things like naps for them if they're doing an overnight shift and they just kind of need to try to get through their shift. This is where I think it's really important for us to give some latitude to those night nurses, for example, where if they need a nap, it's okay, give them that nap. So it's actually encouraged that they take a little bit of a nap. Drinking caffeine slowly over the course of an evening shift to get you through to when you get home to help optimize your sleep then. Wearing dark shades, like think grandma shades, like blocking out all of the light type shades when you leave the hospital, driving home, so that if the light, the sun's coming up, you're not getting that. Having a really dark, again, cave-like environment, blackout shades, really try to create an environment that's dark and quiet if you can, so that you can sleep optimally. This is an area that's really, really challenging because people aren't going to listen to it if they've got to flip-flop their schedule back and forth.
Yeah.
So they might accept that, they kind of go back to the regular circadian rhythm and then they have to kind of flip-flop that. If that's what they're willing to do, then sometimes you can use medications intermittently to kind of help them with that. But like I said, it's theoretically, you try to get them to be on that same circadian rhythm. And it's really hard, especially with people that have those circulating schedules, like the cops who, some people are evening people. They do really great on their afternoon or their evening shift. You put them on a day shift and they're like, oh my goodness, I'm dying from this. So part of it is on the one hand, these are some global broad stroke sort of advice-y type of recommendations for the individual. The bigger question is, do we need to start to construct a pattern of work schedule on a more grander scale, on a cultural level? This is changing culture about sleep in the work environment, which is a big ask, right? To make it so, if you have somebody who has to do a shift, like a police officer or a fireman or something, and they really are on their A game and like they have a naturally delayed sleep phase and they do really good on a particular shift, maybe that's their shift. Yeah. And the person that's early bird and likes to be up and do that shift, maybe you let those people do that shift. And you, instead of like forcing this art, like you must work like this because I told you to, and this is what the rules are, and this is just how we make the schedule, versus trying to recruit different types of circadian people to different types of shifts and doing it that way. That might be more in line with just what works for their life. Yeah. It's a big ask, and then you talk about time. There's an app for people who do a lot of flying called the Time Shifter app. Freaking love this app. It'll tell you you should not have caffeine at this time. You should try to get bright light at this time. You should avoid light at this time. This would be your ideal time to try to get rest and go to bed. If you're traveling and the time shifter app tells you to rest, even if it's a morning flight, this is what I took, a morning flight out to Hawaii for chest this past year. I just followed what the app told me to do. And I saw all these people having their cups of coffee, getting on that plane. And I was like, time shifter said, this is not the right time for me to have it. I'm not having any caffeine. I just had a full night of sleep. Was I really going to get on this plane and rest? I was like, probably not. Had my shades on, just closed my eyes. And believe it or not, even if you're not really getting a deep rest, I did fall asleep for a little bit, like a little mini nap. And so I just kind of tried to follow the recommendations as much as possible. It told me to stay up till 11 p.m. Hawaii time. I was literally like, oh my God, I can't keep my eyes open at 9:30. So I did cheat, went to bed a little bit sooner, but I woke up the next day going, I've never traveled and actually had that much rest in my entire life. So it helped tremendously. So use the technology that's out there that is using circadian science, and it's all built into an app, so you don't have to think about it. That's how I look at it. So I look at things like I'm not getting paid by them to endorse it. I just think it's a great app. So
That's good to know.
Things like that can be really helpful. I'm really curious about where it's going to go, but there's some new discussion surrounding whether or not the timing of when we eat may also help to further align our circadian rhythms. So I'll be curious to see what happens in the future. Like, are we going to have, is the time shifter app going to incorporate when you eat next? Who knows? What's the next permutation of it? So it might come to pass that that'll be really beneficial for us as well. And then there's things like, I just don't think it's realistic, but I will talk about it because people talk about it, which is taking melatonin to kind of start to move your circadian clock depending on which direction you want it to go in. And certainly, if you're planning for a trip in advance, you can start to try to set your clock to kind of match the timing alignment of where you're landing. Like, I don't know. I'm a busy person, and so part of this is my bias as a busy person. I'm just not going to adhere to that. That's like way too much effort to have to plan like a week in advance. I'm just trying to get my luggage together at that point.
Right.
So I don't love that advice, though it's clearly, based and rooted in science, far more than Dr. Kole's opinion. But
Oh, that's all fascinating. And that app sounds really effective. Do you have some questions?
Just a couple. Someone asked, I started using ASMR and white noise to fall asleep. Is this actually better for my sleep, or is it distracting me?
I think that's a great, interesting question. I think there are people that every little thing bothers them, and having some kind of this, numbing of the noise, if you will, helps them sleep better. So I think the proof is, how do you feel with it? If you think it's beneficial and you feel that your quality of sleep is better, it's probably helping you. I can tell you, I've listened to white noise machines. I don't get what the big deal is. I don't find that to be helpful in the least, but that's just me, right? I think they talk all about different types of noise even. There's even something called green noise I've heard of. I love the idea of listening to sometimes like a sleep hypnosis or sleep meditation app. When I'm really struggling, I will put that on, and it somehow for me, it's just about being able to disengage with what's going on in my busy brain. So that tends to be helpful. So I think, if it's a little bit of sound and that helps calm them down, then go for it.
Nice. Next question we had, someone said, I've heard people using mouth tape and nose strips to improve quality of sleep. Does that actually work?
Okay. So nasal strips, there's several ways to do this. There are people who truly have like a nasal valve incompetence. So, when they breathe in, for example, you may see that their nose sort of collapses opposed to stay open like it's supposed to. And so things like breathe right strips, which go over the top of the nose, are just meant to sort of flare and help with nasal breathing, can be helpful. They also make things that are like, there's a ton of brands out there that are like either nasal dilators, like little cones that kind of stent open your nose from the inside. There's ones that kind of clip in your nose and kind of splay out the nostrils from the inside. If you're going to improve nasal breathing that way, and it helps to improve your nasal breathing, I think that's really helpful, because what we know is if you're doing a lot of mouth breathing, optimal breathing is through the nose. And for some people, if there's a mechanical reason for that, you can help with it, and then you can breathe better when you go to sleep. You're going to improve your nasal breathing. You decrease upper airway resistance. So it actually makes the flow of breathing better and more optimal for you. People who mouth breathe tend to get really dry mouth. They tend to wake up like that. It's very disruptive to their sleep because now they've got to sip some water, go back to sleep. Then you're sipping water when you're sleeping. Then you have to get up and pee. It becomes a whole thing. So that's helpful. Mouth tape, I think, is very controversial in my book. And I say that because some people just habitually, their jaw slacks, their mouth falls open. And so they're sort of inadvertently breathing more through their mouth than perhaps is ideal. And they don't necessarily have a nasal obstruction, meaning they have good flow. It's just something that happens with their muscles and their jaw relaxes. In those instances, it probably is helping you because you're sort of training your ability to breathe through your nose. I certainly would practice that while you're napping with people during the day, like not as an all-night experiment. And certainly, too, I like the mouth tape that allows for your mouth to be able to at least open a little bit, meaning that you're not completely blocking your mouth airway. If you've got a lot of nasal congestion, and there's a lot of reasons for that, right? We live in Jersey, so allergies are a big one, right? If you truly cannot breathe through your nose and no nasal strip's going to magically make that better, blocking off the only other way to breathe at night is not a good plan. So I think mouth tape, it's not universal. You really got to be, careful about it. And I certainly think to retrain that connection between being able to breathe through your nose and optimize your breathing, there's something to that. But I will sometimes, if somebody is on CPAP and I know they can breathe okay and they're using a nasal mask, we just need something to kind of help keep their jaw a little bit closed. I might consider something that's a little bit along the lines of a mouth tape in lieu of like a chin strap or something. But it's definitely to be used with caution is how I would put it. I don't think it's a good idea for everybody. And definitely discuss it with your healthcare provider before you go listening to some weird advice on social media, because I know exactly who's been touting all that stuff on social media. I've seen those posts.
Next question we have, someone asked, my kid is a sleepwalker. When he does this, should I wake him up or should I just let him do his thing?
When someone is sleepwalking, that's typically a stage 3 or deep sleep parasomnia. It is actually pretty normal for kids to sleepwalk. What's generally recommended is not to kind of wake them up where they are, but sort of direct them to kind of back to where they need to be. So, and then you just let them sleep. It's the same thing if they're screaming out at night, or sometimes people have night terrors and things that are stage 3 parasomnias when they're kids. If you wake them up, they tend to be very disoriented. They may fight you a bit. So it's better just to redirect them. But I want to reassure you that for the most part, that's sort of a natural or normal phenomenon for some kids in that age group, and they often grow out of it.
Nice. 2 more questions before we wrap up. Someone asked, what are your thoughts on THC marijuana products before going to bed?
You're asking me a controversial and very loaded question. The bottom line is that if you really want to delve into the science behind THC and how it just affects you neurologically, the Huberman Lab just did an amazing 3-hour podcast. So I'm a big fan of people just listening to that podcast to really get into the weeds of it. But this is the reality. I think we don't have enough information on exactly if it's beneficial for sleep on a routine basis. I think the bigger question is, why do you feel the need to have to use something like that? Is it that you're feeling anxious and it helps to mellow you out, right? There's some people talk about it's being studied for anxiety. Is it doing something intrinsically to you that just allows you to feel sleepy? Well, it may work on those pathways, but what are the long-term implications of doing that consistently? I think there's a lot of unanswered questions. So I'm going to just say, I don't pass any judgment on it, but it's not something I can actively recommend at this time because I just don't think we have enough data points. It's been restricted for so long. We just need to study it more.
Nice. And then last question comes from an angry wife. She said, "My husband constantly moves in his sleep, and I'm a very light sleeper. Are there any tips to deal with this?"
Girlfriend, all right, we're talking woman to woman here. This may sound crazy to you, okay? But here are a few things you can do. If you're in a queen size bed, you can upgrade to a king if you have space for that. You can also do the Scandinavian sleep method, which basically is I've got my sheets, he has his sheets, and you are still cohabitating, but you have your own sort of set of stuff, so he's not tossing and turning and disrupting you. And here's where, when you really love someone and they tend to be kind of a disruptive sleeper, number one, get him checked. Like, why is he moving so much? Maybe he needs to see a sleep doctor. But it's okay if you're not worried about him and his health. You can get a sleep divorce, because then you might not get a real divorce because he's not making you crazy because you're actually sleeping. So it's okay if you have your own space and you're like, listen, I need my space. I need it to be quiet. I need to be a certain way. Maybe you have a separate bedroom if you have the luxury of having that space, and you have a Mrs. Suite, and that's where you go when he's being all crazy and you can't take it anymore. Nothing wrong with that. Happy wife, happy life. We all need to remember that, I think.
Don't let Miriam watch the end of this. That's all I have for tonight.
That was
Okay.
pretty amazing.
Because you guys answered most of my other questions.
Yeah, that was excellent. I think this is the type of thing we're going to have like a bunch of follow-ups on, because I learned a lot. And I think it's the type of topic that still we're learning, like, constantly. There's new information stuff. And I want to thank you for taking the time to come out.
Oh, sure.